Well, welcome everyone and good morning. My name is Taylor Chambers. I use the she, her series of pronouns and serve as the Public Health Suicide Prevention Coordinator with the Oregon Health Authority's Public Health Division. Today, I'm also joined by my colleague, Megan Crane, who serves as the Zero Suicide and Health Systems Coordinator, also within the Public Health Division at within the Injury and Violence Prevention Program at Oregon Health Authority. I know that's a mouthful and a lot to remember. Don't necessarily need you to remember that, but just wanted to help frame where we sit in this work, so public health side of this work. Because we are recording this presentation, I do want to add the caveat that we will be referring heavily to our notes to make sure that we really get this information right for you and right for anybody who watches this recording later on. And because we are recording as well, I do want to just make the caveat that we will save questions for the end. So please feel free to drop those in the chat as a place saver for yourself. But we will make sure to get to your questions at the end of our presentation, just to make sure we get through it all in the time we have. So thank you again for joining us for this morning's presentation on telling the story of suicide in your community, a look at state and county level mortality and morbidity data sources. This presentation includes emergency department and urgent care center suicide-related visits and suicide death data. This data does not highlight other data sources such as the Student Health Survey, qualitative and focus group data, Big River programming data, and the amazing work being done around the state by each of you in terms of training programs, awareness activities, and suicide prevention work. I also want to note that some of this data may be challenging to hear, and please step away if that is the case for you. Also, a note from one of our data scientists to say, this is the data that we have available. It's not perfect, but it's what's available. And we'll get into some of that too. So let's start by looking at why is data important to suicide prevention? So data can help determine risk factors and protective factors. These are factors that increase, risk factors, or decrease, protective factors, the chance of a disease or event occurring. So for example, a prior suicide attempt is a risk factor for completing suicide, whereas positive self-esteem would be a protective factor. Data can also help suggest hypotheses. Identifying differences in suicide rates across groups often suggests hypotheses for why these differences occur. For example, the Western and Southeastern states have higher suicide rates on average. Reasons or hypotheses for the regional differences are then proposed and investigated. Data can also help track trends. So for example, public health officials may collect data from the Oregon Student Health Survey to track changes in the number of high school students who self-report that they have seriously considered suicide. If there are increasing reports of suicidal ideation over time, this information may trigger school administrators to implement a prevention program. And data can help evaluate prevention programs and policies. If after determining a trend or pattern in suicidal ideation, for example, school officials may decide to implement a peer counseling program, the school should then track the number of students reporting suicidal ideation on the Student Health Survey or talking to school counselors in order to evaluate whether the peer counseling program is having the desired effect. I encourage you to think about some of the ways that you might use data and how data is important to you when it comes to suicide prevention. So research and data science are centered around the fallacy that data is objective. This is math. These are facts. Numbers don't lie. While the tools of statistics and data science don't carry inherent biases towards a worldview or group, as soon as people get involved, they start making choices that, if unexamined, reinforce their own perspectives in a way that affects the data outcomes and, by extension, the decisions or actions based on them. For example, how are race and ethnicity categories defined? What are we losing by having broad categories like white, Latinx, or Black? Are we asking individuals or providers to categorize individuals? And what is the willingness of communities to provide information due to their mistrust of systems where they have experienced oppression and racism? For example, EMS responders in a quarter of overdoses responses did not include race and ethnicity data. When asked why, they stated, "We do not feel comfortable asking and don't know how to ask," or that they were perhaps unconscious and don't want to assign when they can't ask the client. We still need to do much better at looking at intersectionality between these identities and recognizing the compounding factors this can have on health outcomes and health equity. Intersectionality is the acknowledgement that everyone has their own unique experiences of discrimination and oppression, and we must consider everything and anything that can marginalize people. such as gender, race, class, sexual orientation, physical ability, among others. We're also looking to better understand this data. HB 3159, or the Data Justice Act, passed in 2021, and it requires healthcare providers to collect and report to OHA data on their patients' sexual orientation and gender identity, race, ethnicity, preferred language, and disabilities. And new proposed legislation clarifies that this data is confidential and also requests funding. You may have also heard the term when looking at data of small numbers. We will both use this term throughout this presentation. I want to first emphasize that any suicide is too many. Any individual that dies by suicide deserves the dignity to be included to show value to their life and to be considered in informing prevention efforts. As I've discussed, we need to do work to improve our data systems and address oppression and inequities that permeate through systems, institutions, and society. Small numbers are associated with estimates of lower statistical credibility and an elevated risk of privacy breach. Estimates with few cases tend to be unstable and prone to misinterpretation. For example, it can be hard to answer questions around if certain Oregon youth suicide rates by race and ethnicity are increasing due to the low number of deaths per year. This is where we need to rely on state and national trends, and regardless of the counts, ensure these populations are considered in suicide prevention, intervention, and postvention activities. Additionally, counties in Oregon that have smaller populations and low number of suicide deaths may be limited in how they can use data analysis. State level data may need to be relied on in these cases. For example, looking at state suicide rates by frontier, or remote as we call it, rural and urban county distinctions, we see that frontier, or remote, and rural counties have higher rates, though fewer deaths than urban counties. And just a quick note on the word frontier and why it's here. That's the federal designation that we use, but statewide we're moving towards the language of remote to better reflect partner feedback. So with those important caveats in place and some ground setting background, let's dive into the data systems themselves. Today we're discussing how to access and use data from three sources: Oregon Violent Death Reporting System, Oregon Electronic Surveillance System for the Early Notification of Community-Based Epidemics, and the Oregon Association of Hospital and Health Systems dataset. So Oregon Violent Death Reporting System, or ORVDRS, contains violent death data abstracted from the medical examiner records and reports, death certificates, and law enforcement data. Essence, or the Oregon Electronic Surveillance System for the Early Notification of Community-Based Epidemics, provides real-time data from all non-federal hospital emergency departments and select urgent care centers across Oregon. It also includes emergency department and urgent care center visits for self-harm, suicidal ideation, and suicide attempts. And OAHHS, or the Oregon Association of Hospital and Health System dataset, looks at the hospital admission and discharge data and has 100% of hospitals in Oregon reporting visits related to self-harm, suicide ideation, and suicide attempts as well. ORVDRS is part of the National Violent Death Reporting System funded by CDC, and that collects data from all states. It was established in Oregon in 2003. It collects information on violent deaths like homicides, suicides, and firearm deaths from the Oregon Medical Examiner's reports, Oregon Crime Lab reports, Oregon Law Enforcement Data System, Uniform Crime Reports, the Homicide Incident Tracking System, local law enforcement reports, death certificates, and child fatality review reports. We make this data available to the public through OHA Violent Death Dashboards, which can be found on our website. Additionally, entities that meet the OHA Public Health Division data use requirements can request access to county-level data. These data use agreements can be requested from either Megan or myself. So included in this reported data is information on the descendants' demographics like age, sex, race, and ethnicity, information on the time and location of the injury and death, circumstances surrounding incident like mental and behavioral health status, financial crisis, etc., toxicology test results, substance use history and treatment, occupational group data. But with this data exist limitations. The lack of standardized questionnaires and investigations on deaths in Oregon means death collection and reporting is not always consistent. ORVDRS data does not always include data elements, for example, LGBTQIA2S+ status among people who died by suicide. The data rely on witnesses and contacts of a person who died by suicide, so the incident information is not always complete. Therefore, ORVDRS data may underestimate some given circumstances or risk factors. Here's a look at what the suicide death data dashboard looks like. There are multiple pages to scroll through. Here you see on the bottom of the page is an arrow and a home button. That's how you navigate the page. This is a screen grab of page 2. It does work best in full screen mode, but I do recommend going in and playing around with the data visualizations because there's a lot of information you can get directly from the dashboards. So definitely go in, play around with it, and see what information you can ascertain. Another data source you may have heard of is the Center for Health Statistics, or CHS data. CHS provides death data through review of death certificates. Because it just looks at death certificate data, CHS data is available faster than ORVDRS data. Data is available by state, county, age, race, ethnicity, and sex. It is preliminary death data, including suicide deaths, and are updated monthly through, preliminary death data, including suicide deaths, are updated monthly through the OHA Vital Statistics Death Data Dashboard. But data is finalized 10 to 11 months after the calendar year. So for example, data from 2021 will be finalized, is usually finalized around November of 2022. And then we get more data in February or March from the CDC as well. There's also an injury death dashboard with state and county level data available using finalized data. And to learn more about requesting data, I recommend visiting the OHA Vital Stats data webpage. So here's a brief look at the CHS data dashboard. Always note that this is preliminary data only. Data is updated monthly and past counts may change frequently when this happens. It also has deaths tabulated by county of residence, not where the county of death was. So that's the big takeaway here, is that this is always going to be preliminary data. So it's important to note that the number and rates of deaths will be different between the two data sets because data are collected and defined differently. As a reminder, ORVDRS looks at a number of sources to report on violent deaths, whereas CHS only looks at death certificates. Each of these sources have strengths, and one is not better than the other. It's important to understand what type of questions you're looking to answer to decide which data set to look at. If needing data as soon as possible, then preliminary CHS data may be most helpful. However, if descriptions about deaths are needed, ORVDRS data should be used. The most important thing is to not compare data from one source to another. Instead, compare each source of data to itself over time. You can then look to answer questions like how many suicides occurred in 2017 compared to 2018 based on CHS data. You can, however, use multiple sources of information to describe general trends. So you could say that both CHS and ORVDRS data show an increase in the number of suicides between 2017 and 2018. So now that you have some familiarity around the data set, you may wonder what are some of the questions the data can answer. This is an example from the Suicide in Lane County 2000 to 2016 report. As ORVDRS data collects information on occupation, you could look to answer the question, what occupation group accounted for the greatest number of suicide deaths? Here's what Lane County found. From 2003 to 2015, nearly 4 out of 5 deaths occurred among people actively participating in the workforce, about 78.94%. Here you can see that in Table 9. Nearly 1 in 10 deaths by suicide occurred among people employed in the construction and extraction trades. It is also important to note that over 1 in 5 descendants were not actively participating in the workforce at the time of their death. So how could this be used to inform prevention efforts? That's something I want you to think about, is how could we use this data to inform our prevention efforts, our intervention efforts, and our postvention work? Another question you could answer is how many people who died by suicide had a diagnosed mental illness? In the Suicide in Deschutes County 2000 to 2017 report, they found that 81.6% of people who died by suicide had underlying depression at the time of death. 17.1% of people had bipolar disorder, and 13.2% of descendants had anxiety disorder. This accounts for the top 3 most common underlying mental health diagnoses. This also then may inform efforts on how to work with healthcare and training for healthcare professionals and recognizing the link between mental health diagnosis and suicide risk. Another piece of information you can gather directly from the online data dashboards is what mechanisms are used in deaths by suicide in my county. Here we see that across Oregon, firearms account for 52.1% of suicides, with the second most prevalent means being suffocation at 26%. Whereas in Josephine County, firearm deaths account for 62.1% of all suicide deaths, while in Multnomah County, they account for 37.9% of all suicide deaths. Consider what data looks like in your county to focus suicide prevention efforts. With limited resources, it helps focus where to go to address legal means efforts. And so you can use this data to help inform your county's work. And I'll turn it over to Megan.
So the next data system we're going to talk about is ESSENCE, or the Electronic Surveillance System for the Early Notification of Community-Based Epidemics. So ESSENCE provides real-time data for state and local public health and hospitals to monitor what is happening in emergency departments across the state before, during, and after a public health emergency. Traditionally, this data set is used to track disease outbreaks such as flu. And now we're looking at suicide-related visits to emergency departments and urgent care centers to identify spikes. Emergency departments and participating urgent care centers in Oregon share de-identified information on visits to monitor health-related activity, such as suicide attempts and non-fatal overdose. This information is shared with OHA several times a day so that public health officials and hospitals can alert staff if a higher than expected number of visits occur. We began using this for suicide-related efforts in 2018 when an algorithm supporting suicide-related events was verified, and it has a built-in algorithm to detect higher than expected activity. Approved local public health authority representatives and hospital ESSENCE users can get data daily for their counties or service areas. We include state-level information on the monthly public-facing report OHA sends out, which will provide information on how to get at the end of the presentation. And just as an example here, why do we want to look at hospitalization data and not just death data? As an inverse to suicide deaths, women are more likely to present to the emergency department or hospital for a suicide attempt. Recent ESSENCE data shows that women made up 65% of suicide attempt emergency department and urgent care center visits, compared to men accounting for 35%. A limitation of the ESSENCE data set is that information on factors that may have led the person to suicide or the suicide-related event, such as untreated depression or life stressors, are not included in this data set. Next slide. So a question we could ask through the ESSENCE data set would be how many Oregonians age 18 and under reported to an emergency department or urgent care center with suicide-related visits in 2020 versus 2021? And what do we see in terms of trends by month? Suicide-related visits to emergency departments and urgent care centers for youth ages 18 and under in 2020 were lower than in 2019. There was a decrease in total visits for all health concerns between March and June of 2020, corresponding with the spread of COVID-19. Suicide-related visits to emergency departments and urgent care centers for youth age 18 and under in 2021 were similar to 2019. We are not making the case that we have proofs of less suicide-related attempts or thoughts through this data set. One of the limitations of this data set is that many suicide attempts may not be medically serious enough to require medical attention and are not captured in this data set. It also has to do with coding as a suicide attempt, and this may not be done for a variety of reasons, such as the suicide-related attempt or the suicide-related event not being put in as the primary code by the healthcare provider, which is what ESSENCE primarily relies on, or there might be privacy concerns why another code might be used. Also, hospital data may under or over-report certain communities. For example, individuals with lower income are more likely than individuals with higher incomes to use the emergency department for the care of low-severity medical problems. As a result, hospital data may overrepresent suicide attempts for individuals with lower incomes. This data also does not include psychiatric facilities or veteran affairs medical facilities, since they do not participate in this data system. Recognizing these limitations, real-time data can be very helpful to tracking suicide clusters. And again, the story of suicide is much broader than deaths. When looking at suicide prevention efforts, knowing who is dying is important, but it may be a very different picture for who is attempting suicide or has suicide-related events. Next slide. This is another example of data from Essence looking at suicide attempt visits by age group for those reporting to the emergency department or urgent care centers. So adults ages 18 to 24 have the highest number of suicide attempt visits, while adults age 65 and older have the lowest. Please note this chart represents counts and not rates, so it's not possible to draw an accurate comparison of rates of suicide attempts from this data, but you may be able to look at your county or region demographics to help determine if there are disparities by age in the data. Next slide. So the other data system we're going to look at is the hospital discharge data set from the Oregon Association of Hospital and Health Systems. Discharge data include hospital and emergency department information. Hospital and emergency departments report data to the Oregon Association of Hospital and Health Systems, OAHHS, on visits and stays when there is a charge for services. This information includes diagnosis, medical care received, and demographic information such as age, sex, race, and ethnicity. Hospital and ED discharge data do not overlap in this data system. So for example, if a patient goes to the emergency department first and then is admitted to the hospital, their information will only appear in the hospital discharge data. If a person is discharged from the emergency department and not admitted to the hospital, they will only show up in the emergency department data. We are working on making this data available through some online dashboards. Currently, we provide this data to local public health authorities on a quarterly basis, and information by county is included in the OHA Youth Suicide Intervention and Prevention Plan annual report and is included in the forthcoming OHA Adult Suicide Intervention and Prevention Plan. So some limitations to keep in mind is, unlike Essence, which is fairly real-time data, OAHHS data comes on a 6-month lag, so it's not real-time like Essence. Next slide. So again, as here is just a list of the data elements included in the OAHHS data set. And I would say that this is a newer data set for us in terms of looking at suicide-related events. And I think there's some really interesting things we can look at here. So, here's a list across demographics, diagnosis and procedure information, work-related injury or illness, and then I think costs, including payers, is interesting. So for example, looking at total emergency department discharge charges related to suicide events between 2018 and 2021, they accounted for over $65 million, and then total hospitalization discharge charges accounted for over $100 million. So how do we kind of think about that, and what does that mean? Recognizing that, again, we're talking about humans and people's lives here, but when we're thinking about policy and leaders, some of these things can help augment and strengthen our arguments. Next slide. So as I stated, within the Oregon Association of Hospital and Health System data, there's both the emergency department data set and the hospitalization data set. So first, to just touch on the hospital inpatient discharge data, this data has been available since 2000, although diagnosis classifications changed in 2015. So information after that cannot be compared directly to data from earlier years. Hospitals submit their inpatient hospitalization data to OAHHS in a secure manner, and then an OAHHS vendor cleans and provides data to OHA, who does further quality assurance to share internally. Next slide. So what's an example from the hospitalization data set? What question could we ask? So we could look at which communities are hospitalized by suicide and self-harm. So here we're looking at Oregon residents hospitalized related to self-harm by year and race, ages 10 to 24-year-olds. So looking here, one thing Looking here, we see state data for 10 to 24-year-olds by race. So one thing to note here is that the other and unknown category that relate back to Taylor's talking points about improving REAL-D, race, ethnicity, language, disability data collection. That's something to keep in mind here. And it may be interesting to consider this data in your county, considering the racial makeup of your county to see if groups are disproportionately represented in this data. Next slide. So again, just a note here on the other portion of the OAHHS data set, the emergency department discharge data. So this data has been available since 2018, and same with the hospitalization data. It's available quarterly on a 6-month lag. Next slide. So if we're looking at the emergency department OAHHS data, what's something we could look at? So who is the primary payer for ED visits related to suicide self-harm for 10 to 24-year-olds? So here we can see, again, recognizing this is 24 and under, so we wouldn't expect to see high Medicare coding here, but who is on Medicaid or Oregon Health plan versus commercial. And these could be really interesting data to prompt conversations with health systems and potentially to inform policy discussions. Next slide. So you may have heard my discussions around Essence and the OAHHS data sets and say, well, these seem similar. And how are they the same and how are they different? So Essence for emergency department data is more timely and can show outbreaks or clusters, allowing for a more timely response. The OAHHS hospitalization and emergency department discharge data have more overall information though, and is overall better quality, but as a trade-off, it is less timely with a 6-month lag from the closing quarter date. Used together, Essence and OAHHS data sets can better inform prevention efforts across states and communities. Next slide. So kind of those were the data systems, and now we want to get a little bit more into just, again, building on Taylor's conversation around some limitations or what to be aware of. So shifting back to the Oregon Violent Death Reporting System, mortality, death data. The convergence of identity, politics, and inequality provides a unique opportunity to further explore the complexities of race and ethnicity and to improve the way we collect and use data as a tool for social justice. We recognize and acknowledge that the Oregon Violent Death Reporting System does not capture the complexity, culture, richness, or diversity of Oregonians. Data on race and ethnicity are used to identify health disparities and measure progress towards achieving equity. Historically, the focus has been on having people categorize themselves according to prescribed groups instead of how people self-identify based on their own lived experience. For example, the federal government defines race and ethnicity as two distinctly separate entities, although many may view them as interchangeable and may not distinguish between the two concepts. People who are multi-ethnic or multiracial are expected to choose, or in the case of death, rely on family and friends or medical providers to choose only one that best represents who they are when they may not resonate with them or accurately reflect how they feel. So on population-based surveys, certain racial or ethnic groups are often aggregated or put together to allow robust numbers for analysis. However, broad racial or ethnic groupings often mask important differences between more granular ethnic groups and do not acknowledge important differences in cultural, custom, health beliefs, and practices. So let's look at some examples of how this looks for our Oregon Violent Death Reporting System. Next slide. So here you see age-adjusted suicide rate by race, ethnicity, and sex in Oregon for 2016 through 2020. So some things will pop out pretty automatically to you. We see higher rates of suicide for non-Hispanic American Indian and Alaska Native, and non-Hispanic white boys and boys and men. So when we think about American Indian and Alaska Native, and look at these numbers, I think the important question is to ask, like, why? Why are we seeing this? And I think, again, we need to consider the historical disenfranchisement through genocide and institutional racism that has resulted in American Indian and Alaska Native peoples experiencing poorer health and socioeconomic outcomes. These social determinants of health intersect to create a situation that is detrimental to physical and mental health in Indian communities. So cultural disconnection, alienation, and pressure to assimilate all contribute to higher rates of suicide among American Indians and Alaska Natives. And this is important to keep in mind when interpreting this data. Next slide. So we're going to talk a little bit about what sex looks like in Oregon Violent Death Reporting System. Here you see age-adjusted suicide rates by sex from Oregon Violent Death Reporting System for 2016 through 2020. So gender identity is how a person self-identifies as a particular gender, regardless of biological sex characteristics. What is called sex in Oregon Violent Death Reporting System refers to an individual's gender identity at the time of their death, and it includes transgender identities, people whose gender identity does not correspond to that assigned to them at birth. There is a separate variable for noting if an individual was transgender, and a person can be identified as male or female and also transgender. This data point was added to the data system in 2013 at a national level. Transgender suicide deaths are not separated out in these visualizations due to the small numbers. We recognize this as a limitation of the data set and that it does not allow for identification of people who identify as non-binary or another identity. There is likely an undercount on gender identity data in this data system due to data collection issues, as well as relying on family and friends to provide an individual's gender identity. 42, about 1% of total suicides were designated as transgender in Oregon Violent Death Reporting System from 2016 to 2020. We are not able to evaluate transgender suicide deaths due to small numbers. However, national evidence tells us that transgender women, men, girls, boys, and non-binary people are more likely than cisgender people to attempt and to die by suicide. This is not due to how they identify, rather due to issues such as transphobia, acceptance from their families and communities, trauma of experiencing rejection, and not having access to healthcare that supports their ability to live their authentic lives through gender-affirming healthcare. For youth in Oregon, we can look at the student health survey data for insight. Data has shown students that describe themselves as transgender or gender nonconforming report significantly higher levels of having seriously considered suicide or attempted suicide. So now let's take a look at sexual orientation. Next slide. So a person's sexual orientation is the gender or genders to which a person is emotionally, romantically, or sexually attracted. There is a lack of standardized questions and investigations on deaths in Oregon and nationally that create a challenge for collecting sexual orientation status among people who died by suicide. Relying on family and close contacts for this data can be challenging if the individual's sexual orientation was not accepted or not known by family and friends, especially in the case of youth. Sexual orientation is likely underreported in this data system. Between 2015 and 2019, 5 youth were identified as gay, lesbian, bisexual, or unspecified sexual minority, which is what the categories available through the Oregon Violent Death Reporting System are. 73 people who died by suicide, approximately 1.7% of total suicides, were identified as lesbian, gay, bisexual, or unspecified sexual minority in the Oregon Violent Death Reporting System from 2016 to 2020. For youth, we can look at the student health survey data for insight. Data has shown students who identify as not straight how they do the classification in student health survey, which includes lesbian, gay, bisexual, something else such as asexual, queer, fluid, or pansexual, or don't know, not sure, reported higher levels of having seriously considered suicide or attempted suicide. Next slide. So I think, this presentation is titled Telling the Story of Suicide. And what we've done is gone through some of the data sets that the Oregon Health Authority Injury and Violence Prevention Program kind of oversees and puts data out through. But we want to really acknowledge that those data sets and what we have covered today in this presentation is not really telling the full story of suicide. And so we need to think about what are the other places and spaces that we need to look at to broaden how we tell the story of suicide. So here, really what I'm trying to identify is that within community suicide prevention efforts or a community suicide prevention coalition, do you have coordinated care organization, hospital, local public health authority, and local mental health authority represented? And what data did they have access to inform your work? And here are some examples. So at the state level, we have Healthier Together Oregon, which is our state health improvement plan. And also at the local level, community health needs assessment and community improvement plans are required for coordinated care organizations, hospitals, and local public health authorities. So these reports, these health needs assessment and health improvement plans may identify local surveys, other data sources looking into mental health or suicide, and may also prioritize those issues through those improvement plans, meaning that those specific coordinated care organizations, hospitals, or local public authorities have said they are going to put a focus on that. And so it can be important to building partnerships and getting data. On the lower left here, you can see the OAHHS Systems of Care dashboard, which includes information on youth involved in child welfare and Oregon Health Plan, including some behavioral health data metrics. And on the upper right, the National Survey for Drug Use and Health, NSDUH, provides up-to-date information on tobacco, alcohol and drug use, mental health, and other health-related issues in the United States. We can look at self-reported data on thoughts of suicide, depression, mental health service use, and other measures. And this is available both at the national level and then on a couple-year lag at the state level. And of course, we've already referred to the Student Health Survey in this presentation several times, which provides insight into youth in Oregon. Next slide. We also need to look at specific communities where we know there is limited data available through the sources we have discussed, and consider community and partner information. What reports are either created by those with lived experience expertise or include information from those with lived experience and lived expertise. So for example, on the top of this slide here, I'll just highlight a couple reports as examples. So the Coalition of Communities of Color in Oregon put out a report investing in culturally and linguistically responsive behavioral health care in Oregon, and includes surveying with communities of color on their experiences, perceptions of behavioral health care in the state. Another example in the center here is the Oregon Veterans Behavioral Health Implementation Study, which included survey and focus groups across the state with veterans, those that served in the military, and their families on their experiences as needs. And the Oregon LGBTQ Older Adult Survey Report, which includes mental health and behavioral health information, provides some insight into a population that has been challenging to understand from our other state data sources. On the bottom of the slide, we also need to think about suicide in the broader context of social determinants of mental and behavioral health. So on the left here is a campaign from CDC on how adverse childhood experiences, overdose, and suicide are connected. So, and then on the right is a graphic from the National State Safes Alliance, which looks at injury violence, on how health, community, and social connection, economic stability, housing, education, and behavioral health come together to affect mental health and risk of suicide. So how are you connecting with communities, agencies, and work going on in those areas to cross-pollinate and understand intersections and opportunities to share work and collaborate, recognizing, as Taylor talked about earlier, social determinants of health, but also shared risk and protective factors. And this is something we acknowledge we're also working at the state level. Next slide. So another piece that really can help tell the story of suicide and broaden our understanding of that is really helping tell the stories of those with lived experience, either loss survivors, attempt survivors, those that have chronic suicidality. And I'm highlighting two Oregon-specific campaigns here. Ask the Question project out of Clackamas County looked at suicide attempt, or those that have experienced suicide, and their families, to help really show a picture of what this looks like and how this experience is, and help show how connections and what support has helped them to live what they define as a thriving life. And on the bottom here, we see the Why We Build project out of Lane County, which has a similar aspect of really highlighting individuals and telling their story. So we need to recognize the limitations of what we've talked about previously, and that this representation of individuals is really important to the work, because data is really just summaries of thousands of stories, and we need to tell a few of those stories to help make the data meaningful. Next slide. So I just wanted to highlight a few additional learning or resources that you may find helpful. The Oregon Health Authority has the Injury and Violence Prevention Program data glossary, which goes through much of what we've talked about today in terms of the state level data sources and how to access those data sources and additional information. The Suicide Prevention Resource Center does have a free training locating and understanding data for suicide prevention training that may be of interest to you. And then a new tool that's been developed at the national level is community-led suicide prevention. This web toolkit provides step-by-step information and how to use tools for comprehensive suicide prevention, and includes specific information on data elements and how to use data to guide action and improve efforts. Next slide. So this will be available for you to look at afterwards, but provide some links. I'll just highlight a few things here. In Oregon, we do have the OHA suicide prevention team puts out a listserv message every couple of weeks that provides information on local, state, and national level campaigns, resources, events, and funding opportunities. And you can sign up through this link, or you can email me directly and I can add you. As we discussed, we have the Oregon Violent Death Data Dashboards. I highlighted the OHA monthly suicide-related data report, which includes several of the data sources we talked about, and is available on the OHA website. And you can also sign up to receive that directly by your email when it's released monthly. We have that available for suicide-related data as well as overdose data. And then also just note that myself and Taylor's contact information is on this slide. Next slide. So finally, really just want to close with understanding that this work is hard. Hearing this presentation and some of the data was probably hard. And it really requires persistence and looking at data that can be challenging to live in and day out. So I think it's really important to think about what is the hope that keeps you able to do this work and sustain it? What connections do you have to support you and fill you up? And so this is just a picture of my wife and my dog, and don't forget my dog's ball, which is there too, because that gives her a lot of life affirmation at the Oregon coast. And so really just wanting to close and share that we want to recognize this is really hard work, and that thinking about how we're using data to not only identify who's at risk in our communities, but how to also promote hope is really an important aspect of this work. And so trying to shift as we can, recognizing that understanding the risk factors are really important, but what are the protective factors that we can build and sustain, and thinking about this data and framing suicide prevention work in that way as well. So thank you, and we are happy to take any questions.
Thank you so much for a fabulous presentation. There's lots of wow, amazing in chat. So I hope you two have the opportunity to scroll through and see how appreciative we all are for what a well laid out summary it is of the data sources available. There are a few questions in chat.
Yeah, I can just start, we can go through them. I think we have, just to be mindful of time, we have like another 10-ish minutes, is that right? Mm-hmm. Okay. So the first question I see, and please let me know if I am missing any, but was from Annette. If a coalition is not part of a local public health department, is there a way for them to get permission to see the county level information? What does this process look like? And I think, Annette, you put this in specifically around the Oregon Violent Death Reporting System, but I assume that you probably are asking about the other data sets as well. So because Taylor and I sit within the Injury and Violent Prevention Program at Oregon Health Authority, we and therefore have a very formal relationship with local public health authorities. We already have the data use agreements to make sure that, which really defines how we're sharing data, how data is stored, making sure that we're securely thinking about how we're sharing data. That is already in place. We actually have already identified that, especially when thinking about suicide prevention, that across the state, we have all kinds of different communities doing this work. So we actually are looking at and working with the Association of Oregon Community Mental Health Programs to see about putting how we can put that formal data use agreement in with local mental health authorities to share that data. As we shared throughout the presentation and in the injury data glossary, there are different ways to access this data. And so I would encourage folks to go and look at, especially for the Essence and OAHHS data sets, kind of look through those data use agreements and who can access that data. And we're always happy to provide connections to folks in those programs as well, to understand because there are other systems that can access that data, recognizing that there's a lot of information on the Essence and OAHHS websites on who and how you can access. And if you're not one of those partners that can access that data, we're also happy to hear that, because we always are trying to make more data available, both through getting getting the full data set for your region or county, but also making that data publicly available. So I'll stop there, Annette, and see if that helps answer your question, or if there were any additional questions.
No, that's great. Thanks. I know that that issue you raised about remote counties and privacy, et cetera. I just wonder a little bit about, and at the same time, those counties also really do need to understand what the data is from their community and how to plan. And
again, recognizing this is a limitation, but local public health authorities in any place in the state can, request access to these data sources, regardless of the numbers, right? I mean, what our agreement kind of broadly through the data use agreement would be, use this internally and just be really cautious about how you're sharing this externally. It varies somewhat on different data system, but when you have counts, under 5 or under 10, because that's when we can get into situations where confidentiality can be breached. Let's see, the next question I saw, I think, was from Kathy. Do the underlying mental health issues include substance use and are co-occurring? So in the Oregon Violent Death Reporting System, yes, there are actually over 200 data elements that would be abstracted for the Oregon Violent Death Reporting System, including substance use, alcohol. I don't think marijuana is necessarily called out, but so yes, we do have that, and we do, we're trying to do better at sharing out that data at a state level, recognizing the risk and protective factors across co-occurring conditions. Again, recognize the limitation that, I think we're always trying to look better at how we can collect this better at a death site or around a suicide death. And with over 200 unique factors to collect, I think we need to be conscious of how realistic it really is. So anyway, those are some limitations, but yes, we do have that information. And actually in the OHA Youth Suicide and Intervention Plan annual report, that is included, and there's a section also in the forthcoming Adult Suicide and Intervention Prevention Plan. Kathy, I'm seeing a thumbs up, so I will move on. Another one from Annette, very interested in the list from Lane County on deaths by group. Would it be possible to get something similar for statewide stats? So occupation data, is that what you're talking about, Annette?
Yeah, although I thought I saw in there occupation, and then I thought I saw disability as a category, and I wasn't sure how that was in, but I'm really interested in sort of what are the stats around disability or across the state for Oregon, et cetera.
Yeah, I might have to follow up with you on the question specifically around disability. And of course, since it was specific in Lane County's report, I would always suggest reaching out to Lane County. I know they're also working on an update to their county level report. The occupational data we do have available at the state level, and we can send that out to this group. I believe it's included in the forthcoming, again, ASIP, Adult Suicide Intervention and Prevention Plan, but we are able to look at that data at a state level, recognizing again that, as Taylor identified, those that are not in the workforce, or, what else is captured in that category, maybe occupational data wasn't collected, right? So again, it's a limitation we need to consider with this data set. Sandy, can you send us the link to this? Yes, I believe Alyssa or Jen, I also want the link to the presentation because I think this will be useful for OAHHS to send out. So my understanding is, that link will be available. Taylor and I have already provided the presentation, the data glossary link, and a kind of data menu, thinking about some of the data points from these data sets we've talked about that I am sure will be shared out with the group shortly. And I think that's all the questions I saw in the chat, unless I'm missing any. And of course, if we have a couple more minutes, if there are any additional questions.
I have a follow-on question. One of the shining stars is that Lane County report, and it seems like Lane does dive into the data and try to process it on the local level. One of the things that is so clear from what you've done is that it matters and that there does need to be that local lens because there are real differences. I am wondering sort of like what your sense is on the county and coalition level, the extent to which people are diving into this, and, do you see any role for us as the co-chairs for, do we have a role in sort of, advocating for that, supporting that?
Yeah, so, we highlighted Lane and Deschutes County. Obviously, larger counties are going to have more capacity. They may have dedicated epidemiology or research staff that can support this. What we try, but yes, I agree. Looking at this from a county level, recognizing that may be more challenging for remote counties to do, but potentially multiple remote counties pulling data. So yes, I think it's important to look at it recognize what can be looked at a local level meaningfully, which is something I think, again, with this presentation and the data literacy and support efforts we tried to do at OAHHS, we continually are trying to support. I think the Alliance has a role to play as well. I think one thing could be, how do you getting this information out, like recording this presentation, but, what information is OAHHS making publicly available? Because we do have some data available at the local level. And then, the Alliance, I think, also could connect with coalitions and counties to understand what their needs are and communicate that to OAHHS. So I don't know if Alyssa, if that's getting to your question. Just some thoughts.
It was just a discussion just to get people's thoughts. Do any others have thoughts, particularly around local? And Jen pinged me to let me know that she thought somebody had raised a hand to ask a question. If you have a question, please feel free to jump in. Given that, again, so grateful for the strong foundation you have laid for the work of data and evaluation on this committee, just that general orientation of the resources currently available.